Good afternoon out there, everyone. Dr. Tony Brown coming to you with another edition of Clinical Pearls and Profits. So, today's the first of a little change in our protocol. We are going to approach things by talking about the presentation, what your patient walks through the door with, and then work our way backwards into talking about exactly which labs you're going to order. We will talk about mechanisms of actions, basic science, clinical revelations, whatever you need to cover. Just throw the question in the box. So today, the topic is insulin resistance. Insulin resistance. Now, keep in mind, some of medicine is science and the rest is just language, guys. In other words, we call it insulin resistance. You might also hear your patient use words like metabolic syndrome, right? Both of those may be present in diabetes mellitus type 2. So keep in mind that there's going to be some overlapping between the pathophysiologies that we're talking about. However, at the end of the day, we're going to be identifying the correct labs, whatever name we're going to call it. So, insulin resistance lab studies. So routine lab measurements that you want to do, and there are some that, let's say that you do the routine lab measurements and you get an equivocal answer. That is to say, you can't quite fall on one differential diagnosis or another. If that happens, we will talk about the non-routine labs that you should be drawing. First one, of course, is going to be plasma glucose. Okay, so fasting in some of these, of course, are going to depend on your patients. How much time can they get off of work? Did you decide to do this at the very end of an appointment and they were already in the office, but they haven't fasted? So we'll just give all of them. So we have fasting glucose, random glucose, and then the oral glucose tolerance test. And let's keep in mind, what does it even mean to say insulin resistance, right? The idea is that uh, when I'll use, for example, the glucose tolerance test, when given the glucose tolerance test, the body does not lower the plasma level of glucose to the expected level. It is insulin resistant. It is resisting what insulin wants to do. What does insulin want to do? I think it's always helpful if we think about everything in the body in the context of gas and brake, right? You can push on the accelerator to make things go. You can push on the brake to make things stop. With regard to glucose being inside of the plasma, what we find is insulin is the brake. In other words, it's the job of insulin to reduce levels of glucose in the blood. I know that's a different way to think about it because we normally talk about it in the language of insulin is the key that unlocks the door of the cell so that glucose can go in and then be used for energy. But I want to use the plasma as the center of the universe because it'll help us think about things that happen when our patient goes through different pathophysiologies and disease processes. Okay, so if the point is how much glucose is in the blood, then insulin has the job of stopping that, lowering that. Who has the job of increasing it? Well, that makes it easy. Anything that, for instance, is what we call a stress hormone. When the body is under great stress, when the body is being starved, when you're evolutionarily running from that dinosaur and you need more glucose in your blood to feed your muscles. Okay, an example of a stress hormone is cortisol. When cortisol levels go up, we find insulin levels go down. Why? The job of cortisol is to be the accelerator. The job of cortisol is to be the accelerator. Its job is to induce liver-related gluconeogenesis. Okay, so in other words, the body has said, found me another source of energy. It's not that stuff that's just floating around that insulin's going to take care of. I've got some new stuff that came from cortisol. Norepinephrine, epinephrine, all of these are stress hormones that are created by the adrenal glands, right? The adrenal, you have the adrenal cortex, the adrenal medulla, right? So your cortisol is created in the cortex. Okay, so if we think about it like that, then we realize that when we give this oral glucose tolerance test, what was it supposed to do? It was supposed to put a certain amount of glucose in the plasma and wait for insulin to reduce it. If insulin did not reduce it, then your patient is insulin resistant. Now, on a molecular level, let's just nerd out for about 5 seconds here. What it really means to you people studying for your boards is that you have phosphorylation of the insulin receptor at a serine and threonine position. Okay, there's been phosphorylation at serine and threonine positions. What it means clinically is, your body is not listening. Okay, so insulin resistance may also be associated with hypoglycemia, some autoimmune conditions, and we will go over some of those. Okay, glycohemoglobin levels. That is to say, a lot of you are used to drawing hemoglobin A1C, right? So why do we draw that? The idea here is that usually proteins, I shouldn't say that, usually glucose is not able to attach itself to an amino acid without the help of an enzyme. Now, it may be true that your patient has so much glucose floating around in their plasma that it is able to attach itself to an amino acid. Which one? On hemoglobin. It's able to attach itself to a hemoglobin molecule even without the assistance of an enzyme. We call that non-enzymatic glycosylation. Sorry, the siren will pass sooner or later. So we need to measure those, right? And as we measure them, we're looking for a certain percentage. The numbers will be presented in percentages, and I will go over that scale in a moment. You can also, as we said, check fasting insulin levels. This is a measure of the degree of resistance that the patient may have. In other words, we've already talked about in general why you want to check, do a glucose challenge. This starts to quantify exactly how much insulin the patient might need to be able to metabolize the glucose. Or shall we say, let's just look at it from the back door, it starts to quantify what levels of insulin are being used or utilized before the body starts to resist recognizing this. Of course, you can do a lipid profile. So fasting total cholesterol, low density lipoprotein, and we're going to talk about the different sizes, right? The A molecule, the B molecule. So there's low density LDL, there's high density HDL, there's the triglycerides. Insulin resistance syndrome, which is characterized by having elevated levels of the LDL-B, Bravo. Okay, now let's talk about that for a moment. So there are the LDL-A and LDL-B. The B are the very, very small, densely packed molecules of protein. They are more dangerous than the A. The A are kind of big, right? And they're not as dense. Um, but the idea here is imagine molecules of protein floating through the plasma. If they're floating in the plasma, then they kind of bump, they bump around on the sides of the wall, the endothelium. The sides of the wall are not perfectly smooth when you get down to a microscopic level. They have little gaps and pits and dips in there, right? So what you want to do is you want to pay attention to the level of LDL-B, the very, very small ones that are actually small enough to get lodged in the walls of the endothelium. That's why the B is more important to watch with regard to this pathophysiology. The A, not so much. I'm not saying don't measure it, but the A, less important because those molecules are too large to get lodged and lead to atherosclerosis. All right, also high triglyceride levels and then a reduced HDL-C level. I've got some pictures coming up to talk about the HDL-C. All right, so a combined use of insulin and lipid markers in atherosclerosis. We just talked about that. So fasting insulin, apolipoprotein B, and small LDL levels are more biologically significant than the standard lipid tests. So go on to the VirtualClinic portal, make sure that you choose the one that is breaking apart, that is to say, looks at separately the A from the B. Elevations in the three markers increase the risk of coronary artery disease by nearly 20-fold. So what did we just say? We just said if you look at the B and the A in apolipoprotein B separately, it is a much more sensitive indicator of coronary artery disease. Remember, this conversation started with insulin resistance. So what we just said is you've just given your patient 3 more labs. You've just given them a reason that you need to draw 3 more labs. Now we have a comprehensive lab panel, so that's not something you'd have to keep picking one by one. So how about blood urea nitrogen? Blood urea nitrogen, again, the whole point here is insulin resistance. So the relationship between insulin resistance and blood urea nitrogen is insulin resistance raises your glucose levels. Increased glucose levels increase your odds of diabetes mellitus type 2. DM type 2 eventually leads to end organ damage, especially the kidney. So that's why we're talking about the kidney right now. Blood urea nitrogen, I won't do my little BUN and creatinine fish example. I think I did it 1 or 2 weeks ago. I will just give you the mechanism, which is to say, as BUN is being excreted from the body, BUN is a metabolite of muscle breakdown, so is creatinine. It's supposed to be excreted from the body. However, if you have a very slow flowing glomerular filtration rate, then what happens is this BUN and the creatinine are reabsorbed at higher levels back into the plasma than should be. So therefore, high BUN, high creatinine, bad. It's a sign of a failing kidney. Low BUN, low creatinine, good. All right. Uric acid levels, okay? This hyperuricemia is common and is often considered as a component of the metabolic syndrome. So remember, we started out by saying some of medicine is science and the rest is language. I say metabolic syndrome, you say insulin resistance, he says DM type 2. There are overlapping components in these. With the uric acid levels, though, what we just said is if you have a patient, especially an elderly patient, right, who may be predisposed to arthritic pains, right, rheumatoid arthritis, osteoarthritis, and gout, what you've just done is established a relationship between their insulin levels and joint pains, right? Because as we've spoken about before, uric acid, when the body finally creates uric acid after metabolizing many things that are running through the blood, it decides it wants to get rid of this uric acid. If it cannot get rid of uric acid for some reason, like something else went in the front of the line, such as alcohol, right? Or there is a failing kidney, so it cannot excrete the uric acid. If for whatever reason that uric acid is building up, then that is what leads to the pains of gout. So we just connected insulin resistance with gout. How amazing is it, right, that when you take a stroll through mechanisms of action, that you realize that the body, it's nothing acts in a void. One thing is going to be connected to another in some kind of way. Urinalysis, so this is another way to measure the function of the kidney. That is to say, one of the most abundant extracellular protein in the body is albumin, okay? Albumin, when it rides around, it's probably about 30 nanometers large in diameter. Now, the little slits in the kidney that you do the filtering through, they're 300 nanometers large. Why in the world is a 30 nanometer size basketball not falling through a 300 nanometer size hoop every time it passes through the kidney? That's because both of them, the kidney basement membrane and the basketball, the albumin, both of those have a negative charge. Sometimes things happen to the hoop, to the filtration, where it suffers hyperfiltration damage, for instance, with diabetics, where too much liquid is being forced through, it damages it. Neutrophils come along, do what they do, but they accidentally remove the negative charge. So now all of a sudden your basketballs are coming by and they're falling through the hoop. We call that microalbuminuria. I've got a little bit of albumin in my urine. Microalbuminuria is an early sign of end organ damage that is coming secondary to non-enzymatic glycosylation that's happening in the kidney. Okay, we talked about NEG already, so I won't go back and do that one. All right. Homocysteine. Homocysteine's hot topic, right? Everybody talks about homocysteine. One of the things that you should tell your patient is, sir, when your homocysteine levels are increased, it 1, 2, 3 triples your chances of having a heart attack. Increased homocysteine triples your chances of having a heart attack. Okay, you guys are probably also familiar with homocysteine levels as a measurement of B12, right? We've talked about before how you have methyl tetrahydrofolate floating around in your plasma, and B12's job is to come over and pluck off the methyl and give it to homocysteine. so that homocysteine can now make some stuff called methionine. Very important, because methionine is what is used to make the white stuff, right? The myelin that covers your nerve axons. In other words, your patient's B12 deficient. Nobody's around to give that methyl to homocysteine. Homocysteine just remains homocysteine. It just builds up in the blood. It's been waiting for a methyl. Nobody brought it. It just keeps getting produced. That triples the chance of a heart attack. All the while, the methionine that you should have been making with homocysteine plus a methyl, that never gets made. Methionine's not being made. And now your patient walks in with what we call neuropathy because they're having problems myelinating, most importantly, their spinal cord. So what did we just do? We just found a new reason for you to check homocysteine that is not related to neuropathy, that is not related to B12 and folate metabolism. Homocysteine levels are related to insulin resistance. An elevated level is a risk factor for atherosclerosis, which predicts macrovascular disease. Levels are regulated by insulin. Who knew those were related? Okay, we touched on this one, I believe, last week. The plasminogen activator inhibitor, right? Let's read the part out, get that part out of the way first. So an elevated level is associated with insulin resistance and is correlated to obesity and waist to hip ratio. Specifically, when they say hey, waist to hip ratio, guys, you're talking about this this central adiposity, right? Pro-insulin levels, fasting glucose levels, elevated triglycerides, and LDL. So if you have increased plasminogen, that indicates an increased clotting process, right? Because we talked about plasminogen as something that gets kicked off in the clotting cascade. Okay, so having lots of fibrinogen signifies impaired fibrinolysis. In other words, when the body repairs little bitty damages that might be happening around the microvasculature, you don't want those clots laying around forever. Sooner or later, the body is supposed to absorb them so that one little nick in an endothelium doesn't just keep building up and building up and building up. If you have too much plasminogen activator, that's a sign that you are not able to break down all of the minor clots that are happening in your body. Bad things sooner or later will happen, and that increases your risk of atherosclerosis. And then finally, some other studies would include fibrinogen, testing of endothelial function. So an increased fibrinogen level is a feature of insulin resistance. We've already talked about how the endothelium can dysfunction. And once that dysfunctions, you have NEG, right? We've talked about it a couple of times now. So you have NEG, the non-enzymatic glycosylation, laying down this fresh pink tissue inside of the vasculature. That means that your vasculature lumen is no longer as large as it used to be, which leads to high blood pressure because you've got the same amount of blood floating around in a smaller water hose, if you will. Okay. All right, I think those are the only labs we will have time to get to today. Let me see if there are any questions out there quickly. Happy almost 4th of July. Thank you very much.